So, good evening, everyone, and a very, very warm welcome to yet another learning session from ANEI Patient Safety Fellows. Ladies and gentlemen, Association of Nurse Executives India is very proud about this initiative called Patient Safety Fellowship Program that we conduct in association with Patient Safety Movement Foundation USA. And as committed, we had been holding such learning sessions hosted by ANEI Patient Safety Fellows. This is the 12th of the series, and we are grateful and happy that we could conduct every one of them that we had planned. And thank you to all our audiences for coming every month and engaging in this learning initiative. So evidence-based practices is the domain that we had selected this year. And just a quick one, everyone knows EBP is a process that actually review, analyze, translate latest scientific evidence, and also you tend to find what works for you. So you can also come up with new evidence-based practices, but that is a long process, and that is not too many in our country, but there is enough evidence-based nursing practice out there which can guide us to give the best care to our patients. So, with that intent, we had been this December. This is our last of the series, and we are going to discuss ventilator-associated pneumonia, and that is going to be dealt with Professor Elizabeth Varkey. She is the ANEI Patient Safety Fellow from 2023. This is cohort 3, and I'm just there to support her. And in the end, guide you through all the discussions. So thank you very much. And this is the year end. So let's all say thank you to each other to and everybody else for bringing this years to this level, and look forward to blessings in 2025. And of course, the next cohort of ANEI Patient Safety Fellowship Program will be back with another set of series of learning. It'll be a mix of learning series, and there will be some quality improvement project presentations. So you wait for the announcement of the calendar, but definitely we will be back in January 2025. So thank you so much, all of you, once again for being here. And it gives me immense pleasure to invite Professor Elizabeth Varkey to take this session forward. And Elizabeth is the CNO of Baby Memorial Hospital, Calicut or Kozhikode. Is that Kozhikode,
Yes,
Elizabeth?
ma'am. Co-report.
Kozhikode, Kerala, and this is last of the series. And definitely, ventilator-associated pneumonia is a challenge for all of us. And I can see a lot of ICNs also here, so sure that there is going to be questions and discussions later. During the session, I will request all of you to keep your audio and video off so that Elizabeth is not getting distracted. And I will also be off audio video. And if only required, I'll come in. Otherwise, I'll see you at the end of the session. Okay, over to you, Elizabeth, and all the best. You can unmute.
Yes, ma'am. Yes, just a sec. Shall I share it?
Yes. So,
Is that visible, ma'am?
yes, it is visible. Yeah, thank you.
Yeah.
Just put it on the slideshow. That's it.
Yeah, yes, ma'am. It's on. Okay. So once again, thank you so much for this opportunity, and I am so blessed and happy to be a part of this ANEI, and under the mentorship of Tangam ma'am, we had a great journey with many learnings. So this is my last session in this cohort 3. So this topic is basically on ventilator-associated pneumonia, and I'm so sure and happy that many of the ICNs are here. So it will be a group learning. So today we are going to discuss about this ventilator-associated pneumonia, as VAP. But presently the CDC says about this VA, ventilator-associated events. So we'll be going through that, why and how these has been linked and how this process is going upon. So as an introduction, that we all know that critically ill patients, when they spend at least their 2 days of calendar days and when they are on the mechanical ventilation, they are in increased risk for having various infections, and these secretions are in tremendous amount, and it will be going into the lower respiratory tract, causing this ventilator-associated pneumonia. So this VAP is normally defined as pneumonia occurring more than 48 hours after endotracheal intubation or tracheostomy and initiation of NP. And is also defined by CDC that a pneumonia where the patient is on mechanical ventilation for greater than 2 calendar days on the date of event, with day of ventilator placement being day 1, and the ventilator was in place on the date of the event or the day before. So that's why we call it as a 2 calendar days, and this is what we call, what is the definition of this VAP. So moving forward, we have a way, that is a ventilator-associated event definition algorithm summary, which says that it is totally including all the events associated with this ventilation. It's not only concentrating on the pneumonia aspect, it includes the complete coverage of all the events that happens due to ventilation. So here it says that when there is any respiratory status component, where the patient is on mechanical ventilation, as we've discussed, if it is on greater than 2 days or 48 hours or 2 calendar days, then we have to check for the baseline period of stability or improvement, followed by sustained period of worsening oxygenation, and that we confirm by ventilator-associated condition. So here the chest X-ray is not needed. And when there is any evidence of infection or inflammation component, mainly evidenced by the infection related to ventilator-associated complication, we name it as a ventilator-associated complication. Further, when there is an additional evidence of positive results of microbiological testing, we confirm it as a possible or probable VAP. So this is how the ventilator-associated events definition as well as the confirmation takes place based upon CDC. So now we can see that there is a shift from VAP. You all might be thinking, why this VAP? Now it has been changed to VAE, that is ventilator-associated events. So why this has been shifted from VAP to VAE reflects the CDC's goal in order to improve the reliability and mainly the objectivity of ventilator-associated complication surveillance, because we'll be missing some of the complications associated with ventilation when we just concentrate only on this VAP. So it also helped in broadening the focus to include all ventilator-related conditions, not just pneumonia, and to encourage evidence-based intervention that enhance patient safety and quality of care. Hope I'm audible, and is the space okay? Yeah.
Yes, yes, ma'am.
Yes, thank you. Thank you so much. So what is the significance? You all know that normally this is a common ICU infection worldwide seen, and in the world evidences, when we see that methodology, can see that it is the second most infection of the ICU patients, and there is an increased mortality rate when the patients develop this VAP. There is a prolonged hospitalization, and because of that, we have increased risk for economic impact. They have to spend more amount of their money in taking care when the patient is too much admitted to this ICU. There is impaired recovery. There's a preventability is another aspect, and there are various clinical indicators too. So this incidence states that the evidences as well as incidence states that there is a 38% of cases which are admitted in the ICUs with ventilator develop this VAP. In that, 5 to 10 cases per 1,000 hospital admission, we can approximately say like that. And here there is a comparison in which there's a late onset and early onset. So it says that there is a 31% of patients who are admitted with this or who develop VAP is in the late onset, and 69% is early onset. So this is the incidence that says about this VAP. So what is the etiology of VAP? So you all might be knowing about the early onset as well as late onset. So this late onset, the early onset occurs first 4 days of hospitalization, whereas the late onset occurs 5 or more days into hospitalization. So can you just tell me what are the types? You all are many of the ICNs, and can you just tell me which are the organisms that you come out with when you see with this VAP? If you can just post on the chat boxes, it will be very good so that everyone can see what are the types of microorganisms that you have come up, especially in the early or late, any of the organisms that you have come up in your areas or in the ICUs where you work, where the patients have developed VAP. So if you can, that please share on your chat.
Lot of Acinetobacter coming up.
Okay, okay, ma'am.
More we would Klebsiella pneumonia. Okay.
Yeah.
Again, Acinetobacter baumannii.
Okay, so these are the people who are with us now in the ICUs. So thank you so much for that sharing. Just a second. So here again, when we see about this early onset, it is said that it is associated with non-multi-drug resistant organisms, E. coli, Klebsiella, as you mentioned, the Proteus, have there's pneumonia, Haemophilus, influenza, and aureus. So again, the late onset, we can see it is associated with gram-negative bacilli like multi-drug resistant Pseudomonas, aeruginosa, MRSA, Acinetobacter, etc. So it's something, same thing which you have observed and which the studies and the researchers say also. Here you can see some of the risk factors. This is some of the risk factors associated with VAP, in which we namely name as the endogenous factor as well as the exogenous factor. So this endogenous factor is something inside like the upper respiratory tract colonization, gastric colonization, when the age is more like greater than 60 years old and who are having any underlying illness like ARDS and COPD. Whereas as exogenous factors, we can see like re-intubation or duration of intubation or prolonged intubation is there. When there is any frequent ventilation circuit changes or the type of circuit that we have, the closed or open aspiration in nasogastric tube, supine positioning, the enteral feeding, then the frequent patient manipulation transport out of ICU, chest surgery or burns patients or the patients on tracheostomy, when there is any improper hand washing, then H2 blockers and antacid therapy or previous antibiotic exposures, paralytic agents or sedation, any kinds of nosocomial sinusitis or even red blood cell transfusion. So we'll be dealing in this in detail, and I know that you will be more like authentic to say what happens here. So there are some risk factors which are modifiable as well as non-modifiable, like there are breach and maintenance of aseptic practices, especially when there is any insertion of NG tubes or when there is insertion of this ET tubes. Then position bed when the patient is on supine, duration of ventilation that we have already discussed, enteral feeding, prior antibiotic use, especially when there is any sorts of stress ulcers. And mainly we have the selective decontamination of digestive tract. So we'll be putting some kinds of antibiotic usage also in order to uh, uh, have the sense of selective decontamination of digestive tract. And when there is any witnessed aspiration and even paralytic agents also. And the non-modifiable factors include the comorbidities, the pulmonary diseases like pulmonary diseases, as well as HIV, AIDS, head trauma, any immunosuppression, and even the extreme ages. So these are some non-modifiable factors. So we have to more concentrate on these modifiable factors so as to prevent this VAP. So this is some kind of image. You can see how this mechanical ventilation mechanisms of ventilator or acute pneumonia happens, and this is how the secretions around the tube is being colonized by the bacteria when there is an ET tube, and when there is any insertion of ET tube, there is an impaired natural protection of clearance system, causing this bacteria to be aspirated into the lungs directly to the endocrine tube or around the cuff, causing the lungs has been colonized with the and infected by the microorganisms. So I think we'll be able to see a small video, but this is not a promotion of any company. It has been taken from the YouTube. Okay, so you will be able to better understand about this VAP when you just see this video. So just look onto it for 2 minutes. So I think this is clear to you because with this video itself, it is completely, we will be able to know how this, the pathogenesis take place and how this biofilm is formed. And moreover, the preventive aspects or the nursing care that we have to be more cautious about. So this is a general summary from what we have seen from the video. That's the progression of infection happens, like the upper airway colonization happens. It goes to the tracheal part, and there will be a colonization in that area, causing tracheitis and pneumonia, which is influenced by bacterial load, virulence, and host defenses, mainly because of mechanical, humoral, and cellular defense mechanisms. So this mechanical defense impaired by intubation, and there is a disturbed ciliary motion and mucus secretion, causing this infection to happen. And moreover, there's an artificial airway which will be inhibiting gag reflex as well as the ciliary function. And there's a formation of biofilm because of this pathogen reservoir. We have seen that biofilm role, and this biofilm on artificial airways is a persistent infection source, and dislodging or by suctioning or high pressure airway will be moving this pathogens to the lower respiratory tract. So this is how this pathogenesis of VAP happens, and I think it's clear with this video. So we'll move on to this clinical percentages of VAP. Usually, when it is suspected, when a patient on mechanical ventilation develops any new and progressive pulmonary infiltrates, or when there is a fever, or when the patient has a leukocytosis, and when there is a purulent secretion, so we have to suspect for this VAP. Additional indications include like increased respiratory rate, increased ventilation, decreased oxygenation, or need of higher ventilatory support, mainly the FiO2 and the P, which we follow nowadays. So how do we diagnose that? So mainly the researchers or many of the review says that we can diagnose by means of three criteria, that is clinical criteria, microbiological test, and imaging. So now the CDC does not insist on imaging, but in order to, if the patient is having any sorts of pulmonary embolism or any pulmonary infiltrates, we can go for chest X-ray at least for once. That is what it's been suggested now. So here it says that the clinical criteria, we have the modified clinical pulmonary infection score, we call it as MCPIS, MCPIs, and microbiological tests like culture and sensitivity, and imaging, of course, is the chest X-ray. So this is the modified clinical pulmonary infection score. There is a these are parameters in that: the temperature, WBC count, the tracheic secretion, PO2 and FiO2, chest radiograph, and the tracheal aspirate culture report. So when this has been combined and that has been scored, when the total score is greater than 6, we suspect to be the patient to be having a VAP. So this is a commonly used tool in order to diagnose this VAP. There are some microbiologic tests, especially the specimen, like we have this endotracheal aspirate, the bronchoalveolar lavage, protected specimen brush, and the lung biopsy also. So this quantitative culture states that if the endotracheal aspirate, it is an ET, if it is greater than or equal to 10 raised to 5 CFU per ml. So what do you mean by CFU? Anyone in the chat, can you post what is CFU? And the bronchoalveolar lavage is BAL, we call it as. It is greater than or equal to 10 raised to 4 CFU per ml. And the protected specimen brush, which is called as PSB, it is greater than or equal to 10 raised to 3 CFU per ml. So this is the quantitative culture and how we will be able to diagnose. So can anyone say what is a CFU? In the chat? Can you please put in the chat CFU? There's a unit which we call for any of this quantitative, if we want to measure the quantitative culture, especially on these aspirates or the lavage. Anyone?
Yes.
Colony format
Samsung Krishna colony forming unit.
Excellent. Excellent.
Yes,
It's a colony
ma'am.
form. Yeah, thank you so much. It's excellent answer, colony forming units per ml. So this is how we will be able to quantitatively diagnose that. And the gram stain bacteria, when there's high numbers and if there's intracellular fibrin strands also, we come to the final diagnosis of this VAP. So in the imaging also, we can see such kinds of radiological appearance of new infiltration. The first one, you can see some infiltrations going here. The second, you can see some consolidations here and there happening, and the cavitation here in the absence of any underlying cardiac disease. So this is how we'll be able to identify whether the patient is on the probable to have this VAP. So again, some evidence base says that there's 212 clinical criteria, like radiographic evidence. When you take for 2 consecutive days, when you see any sorts of new progressive or persistent infiltrate or consolidation or obesity or cavitation, there is one chance of that. And again, the first, at least of one of the underlying following symptoms like fever is greater than 38 degrees Celsius with no other recognized cause, and the leukopenia, the values are here, or there is some leukocytosis. And again, this 212 clinical criteria says that if there is at least 2 of the other following, like new onset of any purulent sputum, or there is any change of the character of the secretions that is coming up, and any new onset of worsening of cough or dyspnea or any tachypnea, and rales or bronchial breath sounds. Here comes the importance of nurses here. I think ma'am can add on to this some more into this bronchial sounds, or you will be coming up now or the later?
I'll come in later. Yep.
Okay, fine. So rales or bronchial breath sounds when we do the auscultation, then and there we'll be able to capture out whether the patient is on the like about to develop this VAP and any sorts of worsening gas exchange also. So this is the NHSN surveillance diagnostic criteria of ventilator-associated events. So we were discussing about the VAP. So even here, this surveillance diagnostic criteria have come up to identify what is this ventilator-associated events also. So in this, they say that the stage 1 is a VAC, which is a ventilator-associated condition, in which the device criteria is that presence of device at least for 2 calendar days, as we already mentioned. And when there is any worsening oxygen criteria, like when we observe the baseline FiO2 or PEEP when it is stable or decreasing for 2 days, followed by any increase in this FiO2 or PEEP for 2 consecutive days, we confirm it is to be a ventilator-associated condition. Now, the stage 2 is the IVAC. This is the infection-related ventilator-associated complication. That is a ventilator-associated condition plus the following criteria. So that comes as we'll be seeing that the patient will be having fever, hypothermia, or leukocytosis or leukopenia. And in the antibiotic criteria, if you see new antibiotic agent started and it has been continued for greater than or equal to 4 days. Then on the stage 3 comes up the PVAC, that is a possible ventilator-associated pneumonia. So IVAC plus the culture criteria. So in culture criteria, we can see isolation of respiratory pathogen from lower respiratory sample. So this is how it has been followed we'll be able to see the ventilator-associated condition, the infection like IVAC, the various associated complications, and finally the possible ventilator-associated pneumonia has been diagnosed. So we'll see some of the evidence-based practices here to prevent them. Normally, we say that there is a 3 most common mechanisms which develop this VAP. Is because of the aspiration of any secretions, colonization of the aerodigestive tract, as well as the use of any contaminated equipment. So in order to prevent this VAP, these are general measures to prevent that. Here, there are the certain general strategies. We have to prevent aspiration, we have to prevent colonization. We can use various kinds of VAP prevention bundles, and we have to avoid intubations. So we'll go into detail about this. So in this categorization of avoid intubation, it is always recommended that we have to use non-invasive invasive ventilators instead of invasive ventilation, and wean or extubate early so that there is no chance of prolonged ventilation and causing the further complications and events happening associated with this ventilation. And we have to prevent colonization. For that, we have to adhere to the 5 moments of hand hygiene. We have to use the standard precautions when manipulating airway, the gown, gloves, and goggles. Use inline suction device, avoiding instilling normal saline routinely down the ETT. There was some practices previously, like we'll be instilling some normal saline in order to lubricate the secretions and all. Then change ventilator circuit every 7 days or when soiled. Use single suction catheters only and remove oral secretions before performing ETT suction. And moreover, we can see that when there is continuous parenteral administration, or we can see that there is continuous feed when it is being provided, while we change the position of the patient also, it is highly recommended that we stop that, or we have to suction the oral cavity and then oral as well as the ET tube. Only then we have to position the patient, because there is a chance for this dislodgement of the secretions into the trachea. Now, to prevent aspiration, we can use meticulous oral and dental care. We have seen it. Drain ventilator condensate away from patients. Maintain safe endotracheal cuff pressure. Maintain 30 to 45 degree patient elevation. And when coming into the general aspects, daily sedation, wean and extubation readiness trial and spontaneous breathing trial, which is we call it as the SAT and SBT. We have to use the antimicrobial stewardship, minimize ventilator circuit manipulations, because any kinds of vaporization, anything can also dislodge to the patient tubings and cause those kinds of infection. Do not use PPIs routinely. DVT prophylaxis in appropriate age group. Perform family education regarding infection control measures, and adequate staff-patient ratio is also an important aspect in preventing these kinds of infections, especially in patients who are critically ill and in the ventilators. So we'll see about this VAP, but in detail. You all know that these are the 6 aspects which we see. That is, the head of the bed is elevated to 30 to 45 degrees. Oral care every 8 hourly, DVT prophylaxis, ulcer prophylaxis, daily SAT and daily SBT. So we'll see one by one here. This is the spontaneous awakening trial, which is a SAT we call, and the spontaneous breathing trial is important. And we have to consider the extubation to NIV, as I already mentioned, to the non-invasive ventilators. And the head end of the bed has to be within 30 to 45 degrees. The cuff pressure should be greater than 20 centimeters of water. Why do you say that the cuff pressure should be greater than 20 centimeters of water? Why it should not be less than that? Anyone? Can anyone answer to that? we say that it should be greater than 20 centimeter of water, the cuff pressure. Why not less than that?
Risk of aspiration is there.
Okay. Why? Yes, that's good. That's an answer. But why this 20 centimeter of water we mentioned, the cuff pressure? Anyone? Okay. Okay, fine. So that, yes. Yes, ma'am.
I will discuss a little bit once you finish, because
Okay.
you asked a very important question, why it is 20.
Yes.
The answer, okay, it will prevent microaspiration, but it will prevent microaspiration even if it is maybe 21, 22, 23, 24 also. You never know. Okay. So
Okay.
there's a little bit of disconnect. So irritation to mucosa. Okay, we are getting in bits and pieces. The answers are coming in bits and pieces. So we'll put it all together once Elizabeth will
Okay.
the discussion. Okay.
Okay, okay, ma'am. Okay, so yeah, this is a time for thinking. You can also think why that is happening. Even you can ask to any of your lifelines also. Okay, so that it will be interesting to see. Now, finally, we can see avoid nasotracheal intubation NG tubes. We mentioned alkyl decontamination. Even some researchers say that silver-coated ETT tubes also prevent from these kinds of biofilms. The prevention of biofilms, the formation will not be there, and secretion clearance closed open suction. It's normally said the closed suction is better than the open suction, and the prevention of this saline installation. And as, of course, we have discussed about stress ulcer prophylaxis. So there's a completion of all these evidence-based strategies to reduce this aspiration and infection. So first and foremost, we mentioned about this hand hygiene with the appropriately and the use of gloves. And here we have the semi-recommend position, that is 30 to 45 degree. So here again, we have to maintain this oral hygiene with 0.2% chlorhexidine or brush and suction at 8th hourly. And finally, we have not finally the peptic ulcer disease prophylaxis has to be maintained. So in this semi-recommend positioning, like it says at 30 to 45 degrees. So there is also significance for that. No? So in order to prevent the aspiration, that is the I used to put it. But here nowadays we have some kinds of beds also, which is aligned to these kinds of preventive aspects, and which we can see this ankle indicators, and which we'll be able to really place these kinds of patients into that particular elevation level, so that it is properly maintained, because we will not be able to know what degree the patient is presently now. So even the nowadays the beds are also such customized, like we will be able to identify these kinds of ankle indicators. I hope that many of your hospitals might be having the same. And again, we have this DVT prophylaxis. So why do we call this DVT prophylaxis? What is the relation of a DVT with a ventilator-associated pneumonia? You might be thinking, even I had thought, like, why this DVT and this peptic ulcer comes in like in collaboration with this ventilator-associated pneumonia, something to the lungs and the other thing is to some other area. So that is a question where we can also discuss about. Okay, so any answers to that? Okay, so I'll just share one thing here that will be more in, like, there's no direct impact, no occurrence of DVT. So when there's an increased length of stay, and then that is causing increased ventilator days, so there is increase of chance of VAP. So that will be causing this kind of increased stay, will be causing this pressurization to the areas, and the patient may have DVT. And that's the one reason, like mechanical or pharmacological interventions can be provided for that. So now we'll see, like, what is the what are the activities to be done for the SAT, as we mentioned, the spontaneous awakening trial and the spontaneous breathing trial. So we have to assess the compliance is occurring every day on multidisciplinary rounds, whether it is done, and to consider implementation of a sedation scale. Normally we use a Rickert scale to avoid over sedation and agitation. So some of the hospitals use that. So what is the implementation phase here? So in this SAT, that is spontaneous awakening trial, we have to implement a protocol to lighten the sedation daily at an appropriate time, especially this normally the early morning, to assess for any neurological readiness to extubate. So this here include the precautions to prevent self-extubation, such as increased monitoring and vigilance during the trial, because the sedation has come to the lower level. So there is a chance for accidental removal of this ET tube. So we have to implement a protocol to have this light sedation, so that we will be able to see whether the patient is ready to be extubated. And we have to include a sedation vacation strategy in our overall plan to wean the patient from the ventilator. If you have a weaning protocol, we can add a sedation vacation to that strategy. And regarding this SBT, that is a spontaneous breathing trial, okay, we can have the CPAP trial. I am sure that many of your hospitals will be doing the same thing. We will put the patient on the CPAP, and for 30 minutes, we'll be seeing that daily once it is being done, and the constant vigilance, we'll be able to see that whether the patient is able to spontaneously breathe. So this is how we can have prevent from, like, all these muscles will be working on it, and we will be able to prevent many of the infections or aspirations. Now, some evidences says that an in-depth look at ventilator-associated pneumonia and trauma patients and efforts to increase this bundle compliance. It says that after the implementation of the VAP bundle, there was pre and post implementation of the VAP bundle. They can see that there was pre-implementation of this VAP bundle, there was a 12.2% of patients having this VAP, but after implementation, they could see that there was the VAP was decreased to a certain level. So here we can see the recent advances in this VAP. We have certain kinds of quality indicators we come up with to see the VAP rate calculation, cases per 1,000 ventilator days, compliance with bundle care elements, monitoring antibiotic usage and resistant patterns, and number of reintubations also. And there are some technologies have come up with, like closed suction systems is introduced. Before and all, we used to have this suction with a normal saline and then we dip and such kinds of things. So the closed suction system have totally prevented from any entry of any infections, and advanced humidification devices like this HME. Then brush suctions also have come up to such a greater extent that it has prevented, helped in preventing VAP, rather than using our traditional method of the sponge and the the artery forceps. So that normally you have seen in the video also, when that has been used, there is a chance for squeezing of some amount of water into the mouth that is will be going into the lower respiratory tract, causing these kinds of aspirations and even the pneumonia. There's a cause for that. So this kinds of suction have come up, which will be helping to brush at the same time. We will be able to suction from these kinds of debris. And AI and predictive analytics have come up, like it will be popping up to say that when you enter all these kinds of patients parameters, automatically there are coming up with the various monitors in which the AI tells you that the patient is at risk of developing VAP with all these indicators. And early detection and intervention is the main aspect of new technology. So there are various kinds of projects and coming up, like we have to start with certain evidence-based practice to improve it and to become excellent. So we should be the heroes in maintaining or preventing this VAP by means of interprofessional team training, as well as electronic reminders, checklists, and regular feedback to the team. So that's all about the VAP, and we have some kinds of takeaway that you can remember always, like shows no VAP. So we'll always remember that. Shows like C for cuff pressure greater than 20 centimeters, H for head and elevated by 30 to 45 degrees, O for all decontamination with chlorhexidine, S for suction, subglottic secretion, and stress ulcer prophylaxis. Normally we use sucralfate or any sorts of antacids. Enteral feeds, N for no saline lavage, O for orotracheal intubation, V for vent circuits to be changed only if needed, A for avoid heavy and continuous sedation paralysis, and P for prophylaxis for DVT. So this will be helping you to remember, this acronym will be helping you to remember what are the measures or the evidence-based practices to prevent this VAP. So finally, as I mentioned, you should be the VAP heroes. So this also will be able to help you to find out H for hand hygiene, S for suction, E for exchange canisters, as we mentioned about these HMV and all, the oral care repositioning and the exchange of oral suction. So with this, this VAP has been causing tremendous infections to patients when they are for a prolonged period on the ventilator. So VAP prevention, when we as the heroes of preventing VAP, we can save lives when we adhere to the various evidence-based practices, and that will be reducing the morbidity as well as the mortality of the patients. And the key strategies like implementing the VAP bundles or promoting early extubation and the maintenance of strict infection control practices and minimizing the risk factors also will prevent the patient from having this condition. And when there's a multidisciplinary approach with collaboration among the health team members, especially respiratory therapists, play a major role in helping to prevent these kinds of infections, and timely interventions also needed. So focus on patient safety, like shifting to broader ventilator-associated events frameworks will be improving more outcomes and care quality instead of just concentrating only on one condition of VAP. So commitment to excellence, continuous education, surveillance, and innovation are crucial in the fight against VAP. So we have a greater role here. As I already mentioned, the heroes are having a greater, you have to provide the best part in preventing such kinds of infections, so as to, which could be a really preventable incident or really preventable infection in our daily routines. So with this, thank you so much. And I invite Taga ma'am for the greater discussions.
Thank you, Elizabeth. Thank you very much, and good flow of content and a lot of content. So thank you very much, and I hope there had been some discussions online. Thank you for engaging. So we still have some time to spend time on, have bridging those little gaps that we have had. So I'm okay if one of you want to unmute and answer the questions. So if need, kindly provide it, kindly fill up. Okay. There is a feedback link that is, given to you. You can fill up the feedback if you want to get a e-certificate. So let's, discuss the questions that Elizabeth has asked during the session. I think the first question you asked was about what the connection between DVT and the peptic ulcer prophylaxis. So this is also my very frequent, pet question to ask all the ICNs when I train them. What's the connection between the stomach and then the legs, which is very far away from the lungs? So you have given kind of, correct answer. Anything that will increase the ventilatory days will definitely increase the risk of VAP. That is the fundamental reason. So if you have the stomach content which are very acidic, and also it can colonize organisms because you have already altered the airway, you have put a tube in there. So the normal microbiome which is there will be disturbed, so there can be biofilm, and in case the patient in some position, in case any regurgitation all happens, that content will get into the lungs and it can lead to more pulmonary complication, more longer stay, then risk of you can't extubate the patient if they get any complication. Very simple as that. The same story with the VAP also. Sorry, the DVT also. Because we know they are on bed, you know the reason, and you are giving DVT prophylaxis. So if you don't give, they can develop complications related to being on the bed for longer time. So that can lead to the potential chances of pulmonary embolism. And pulmonary embolism means you can't extubate the patient. So more, again, longer days of ventilator days, increasing the risk of, VAP. So that's the connection. So now interesting question, one more was that why the endotracheal cuff pressure? Can anyone answer that? Any ICU nurse or any ICN? You can try to answer why there were two answers. One was that it will injure the mucosa. The other one was microaspiration. So that these are the two spectrums. Can someone put it all together and give one answer? What is your normal airway pressure range in your ICUs?
21, ma'am.
Okay. It's actually a range based on the patient's anatomy. Small bodies will not have large trachea. Obviously, huge patients would have larger trachea. So there is a range. Usually it is between 20 to 30 centimeters of water. So anything less than 20, the risk of aspiration is higher. And anything more than 30, the risk of ischemia and trauma to the trachea will be higher. Now, what is the procedure do you follow to ensure the right amount of cuff pressure? This is the ICU question. There are
Use of
there were two techniques we used to use when I was in the ICU. So usually you are doing the cuff pressure. The cuff pressure does not mean it's the right pressure for that patient. So how do you know what is the right pressure for that particular patient? How do you do that? No. Calculator is actually for measuring the pressure. That's a range. How will you know that for patient A is 22? That's the optimal pressure for that patient. For another patient, it could be 20. For another patient, it could be 25. How do you know that is the I'll give you some time. I know where you people will go and ask the question also. Let me see.
size of 80 tube.
No.
Ma'am, normal range of cuff pressure is 25 to 30.
No, no, that I know. My question is not that. My question is, how do you determine what is the right pressure for a particular patient? Because we really don't know the size of the trachea of the patient, no? Any ICU nurses here, at least those who are practicing nurses should know about this. I know this, it's only because we used to follow that one of the techniques. There are two techniques. Okay. Maybe in your ICUs it is not being followed. So the doctor says it's okay as long as it is between 25 to 35, or there is a range that is given. The two techniques that we used to use is called the minimum occluding volume or minimal leak volume. So what we actually do is we actually keep the stethoscope here on the side, and as you inflate the cuff, minimum occluding volume is when you keep here, when the ventilator is working or ambu bag is working, you can hear the air leaking. So as you increase the pressure, at one point, it's like taking BP, the leakage will stop. So that is called the minimum occluding volume technique. The minimal leak volume technique, we actually just put up the pressure and then slowly release. And when you get a minimal leak, you stop. But minimal leak volume is not a technique that, at least in our ICU, we did not prefer, because we were not very sure how much of leakage will each nurse or a junior doctor will leave. So we used to have a protocol where the two nurses will be doing this one-time measurement carefully to see that what is the pressure that we need to maintain for that patient. So we used to do the minimal occluding volume. And that was determined not by every assigned nurse. It will be determined by the experienced TLs or the in charge. So they will be the one who will actually say, okay, the leak stopped, because you should have experience of listening to that sound, right? If you are not used to it. So once you do that, you do it multiple times, you actually become very good at that. The size of endotracheal tube, it kind of indicates what is the volume. See, the most unreliable method is to feel the pilot cuff. Many times we go and check, no, it's okay. We go and check and see, oh, is it okay or not? The pilot cuff should be slightly inflated, or it will say how many ml can you inject. Okay, these are all not foolproof, but if you learn more about it, these are the two techniques. It's good to know. And in case you are not using, you can go and ask the doctors also, why, what is this technique? And if you read up, you will find this. So cufflator is definitely, so once you measure, then you can write on the flow chart in red to say that for this patient, usually if we measure 22, we will write that it should be more than 22, less than 22. We give a range of 2, so which is okay. The if you have too much pressure before ischemia, it can also lead to something called tracheomalacia, where the tracheal rings, they get paralyzed. Then it is very difficult to keep the cuff in place at all, because the rings are no more working. So whatever you inflate, it will be still leaking, you know. So these are experience I have had years of being in the ICU. So if anyone of you have anything new to add, offer, we'll be very happy to hear, because this is a collaborative learning environment. Was there any other question that you asked that is not answered? I'm not able to
Ma'am,
recollect.
auscultation of lung sounds.
Yes, yes, yes. So that's an interesting question to ask, because when I came back from abroad and when I came back to India, I was very surprised. The nurses were using stethoscopes only to take BP. So anyone sitting here, can you please motivate me by saying that our nurses also use the stethoscopes to auscultate the lung of the patient when they're in the ICU at least? Please, I would love to hear that. I will say, okay, future is good.
Okay, ma'am.
No, not okay, ma'am. I want to know whether any one of you, any ICU nurses at least are auscultating the lung to verify whether the lungs are clear, whether there is a need to suction. Please remember, there is no standard recommendation to suction a patient on ventilator every 2 hours. It's only suction when it is required. Many times you start putting the suction catheter, it is increasing the risk of VAP, correct? So if you
Yes.
know to listen with stethoscope, you can decide, okay, now it is time to suction patient. You know air entry is clear, not clear, is there a problem coming up? So anyone here in your hospital, in your ICU, your ICU nurses are using stethoscope to listen to the lung sounds.
Yes, ma'am. I used to auscultate, ma'am, when I
Not
was in
you. No,
ICU.
no. You did, I did. So my question is now,
Yes.
who is now?
Yeah, yeah. Yes, yes.
Current staff
Present
nurses.
scenario.
Correct.
Present.
Yeah.
Yes.
Are they doing it? So why did we stop that? So I would really love all of you to think about it. We always keep asking for more recognition, more respect, more status. And believe me, if we become clinically very sound and we can do what we are trained to do, we are taught about the lung sound, right? And we are supposed to use the stethoscope. We learned about the stethoscope. So when we don't do all this, we don't get the respect that we actually deserve. It's only because we are not practicing to the top of our education. So now I'm very sure the nurse practitioners will be doing all this. But when we learned nursing, we said how to examine a patient. We will say, okay, palpation, percussion,
Yes.
auscultation, all the
Manipulations also.
all the Asians will be told
Yes, yes.
clearly. But imagine who will be doing this, actual assessment. So forget about, the stethoscope. Sometimes we even fail to use our hands. So I will like to share a story because I love stories. Stories are powerful. So this when I was in the I was in the hospital as I get a call. The call is from the urologist who says you need to talk to your nurses. So what happened? A patient who had herniorrhaphy, was transferred to the ward. Okay. So in very minor operation, he's on the bed. So after a few hours, he said, I have pain. So the nurse went and looked into the file, what pain medication. Obviously, she asked the pain scale. She gave the medicine. And after some time, he said, he's holding his hand in the lower abdomen. That's because that's where the surgery is. So he says, Sister, pain. So she says, you got medicine. I can't give you more medicine. He said, call the doctor. So the nurse calls the doctor. So he says, okay, maybe you can give him this medicine also. So that medicine also given, but the patient is not relieved of his discomfort or pain. It's a young patient. So evening time, the surgeon comes for rounds. So when the patient complains, the first thing he does is go and see the site, right? It's very natural. So when he just opened, so what did he see? He saw a very distended bladder. So patient is saying what he feels, that's his pain. But we are trained to assess the patient. So when a patient gets surgery, if a patient says pain, you don't just simply give medication, no, you will assess the site also, right? What is there something happening there, right? And when he called and told me, I didn't have an answer. I felt so embarrassed. But only saving grace, I told him, sir, your doctor also missed. It is like giving a very lame excuse. So my dear friends who all are here, I would definitely request it is time that we should use all the skills that we have been trained to do. As you gain experience in a particular specialty, Start learning more, understand what we are doing, why we are doing, and use all the skills that we have been trained to do. Otherwise, I feel that we will be still fighting the same battle even after 10 years. Shubhangi told she used to do. I am telling I used to auscultate. Then what happened now? So, a request to all the leaders also sitting here, let's start training our ICU nurses at least to do a bit more of auscultation. And now there are a lot of tech-based solutions available. You can actually hear what is a ronchi, what are rails, the minimal crepitations, basal crepitation, all these, sounds you can hear. And once you start putting the stethoscope on the patient's chest and start identifying. I know young nurses, I know I used to be very excited to put the stethoscope, listen, and then call the doctor and say, am I hearing bronchi? Or is it called the crepitation? That's how I learned. Then somebody will tell, that this is what it is. Abroad, we had this teaching stethoscopes, which can be shared by the doctor and by the nurse. So we had that. So we both can listen, and then I can tell, and the consultant will say whether I am right or wrong. So we had to train all our nurses on some heart sounds, lung sounds, bowel sounds without any question. So just sharing all these so that we all try to up our game. Then I am very sure that everybody will start noticing who are these registered nurses. Otherwise, others will come and take your place. Please believe me. If you are doing bare minimum to our patients, they'll find other people to do bare minimum. We have to show to the organization we can do the basics and we can do the high-end thinking. That can only happen when we have high-end skills, which are there in our curriculum. So let's do that. Anybody would like to say, share, comment anything before I ask Elizabeth to tell her final words and we will wrap it up? Anyone in the audience would like to share something? Everybody is quiet. They are thinking too much.
Yes, ma'am. I think they're thinking like how to go about the insight that you have given on the auscultation and other methods of inspection, palpation, and all those. I think they are coming over. And
Okay.
some questions there. How it's about the pediatric something they are asking.
Okay, let me see. I'm not a pediatric person. I will still look at this. How it is I mean, you mean the cuff pressure? Yeah, I don't have the pediatric experience, but there will be a range for them also. But it is the same. In a pediatric patient, there is no leak method at all. It is minimum occluding volume. So you have kind of a benchmark when you look at the cuff volume because all the endotracheal tube will give a cuff volume. So you have kind of an idea, but then use the stethoscope, and that auscultation is done on the side of the trachea, not on the chest. So when you are, in the ventilator, when it is working, you can hear the air is leaking. So when you're in doubt also, you can check, because sometimes your minute volume will start falling down. It will give an alarm. So if the cuff is leaking, your minute volume will come down. That is one of the reasons, right? When the volume comes down. So that is it. So somebody's telling too much, too much new learning. It is not too much. You already learned all this stuff. Okay. I think all you have to do is have the courage to go and, start practicing and enjoy being that smart, thinking nurse that everybody is going to look up to and say, oh, wow, that's the nurse. I really feel, that is the way that we should do. Yeah, maintaining cup pressure is equally important, true. But yes, the process is the same. Okay. And yes, in neonates, many a times you are using non-cuffed tubes. We don't use cuffed tubes there. There, the challenge is just to keep. And yes, one of the things that Elizabeth mentioned is also when you don't have closed suction, the subglottic suction. That means above the cuff, the secretion which is there must be relieved. I mean, you have to suction. That's why the oral suction becomes very important. So there is no secretion sitting on the cuff, over the cuff. So if the cuff leaks even little bit, if there is any fluid sitting up there, you saw in the video also, it will simply go inside. So I think this is very important to keep in mind. So thank you for all the positive feedback. We are really happy that you're coming and learning. And we will definitely be back in the new year. And all of you, you are part of the last session of the ANEI Patient Safety Fellows. Thank you and God bless you. One more year, we can close this year with a lot of gratitude, a lot of good things have happened. And not everything is good. Maybe there were rainy days, that's fine. But there is always sun coming up after the rainy days. So I'm hoping and praying for all of you to have a fantastic new year and a very, very happy Christmas as well. And stay blessed. And over to you, Elizabeth, to say your last words.
Yes, ma'am. Thank you so much for such a wonderful session. It was really motivation for everyone, and the way you have expressed your learnings as well as your experiences. So I think we have to go more high. You are trying your level best to upgrade this nursing profession to such a profession, stating that something different. So I think everybody should feel that these people are different from others. So with that word, ma'am, wish you also a very happy and fruitful year and a Merry Christmas to all of you. Thank you for all the patient listening
Thank
and all your
you.
guidance.
Thank you, everyone. So
Yes.
maybe, Elizabeth, you should start having auscultation.
Yes,
challenge.
definitely.
We'll start having in that energy to start learning, Yeah,
Yes.
fantastic. Thank you, everyone, and good night and take care.
Bye,
Thank
ma'am.
you. Thank you
Bye.
so much. Bye.
Bye.